Hello, my name is Dr. Freddie Garcia, and I'm going to shoot a quick introduction video to a video case review series that Dr. Concussion has put together for us. In this series, he's going to give you his clinical thinking process to working with patients that have experienced a concussion. And he's going to take you through some various scenarios, from the acute concussion to the subacute, and eventually those who are experiencing chronic and persisting symptoms from a mild traumatic brain injury. If you have a desire for clinical excellence in the management of concussion, please visit carrick.com. But without further ado, on to the video case review. Enjoy.
Today we're going to be talking about the acute management of concussion. We're actually going to be walking through a case study of a woman who's an actual patient of mine. We're just going to call her Beth for sake of anonymity. And we're going to talk about how we managed her acute concussion. There's a lot of people out there that are seeing concussed patients or want to see concussed patients, want to help that group of people, and just don't know how to approach it. So that's the whole basis of the functional neurology management of concussion. It's about diagnosis of concussion and management of concussion, hopefully to a point of rehabilitation if we can. So without any further ado, let's get started on this case. Before we do this, we're going to give a little bit of background on concussion. Concussion itself has us all shaken up. There are over 30 different definitions of concussion purported in the literature. And as a matter of fact, the word concussion itself is almost solely used to describe sports-related mild traumatic brain injuries. Individuals who are non-sports or in the civilian world or in the military world, we call concussions MTBIs, or mild traumatic brain injuries. All concussions are mild traumatic brain injuries, and all mild traumatic brain injuries are essentially concussions. However, there seems to be some disagreement between what we actually call them, and a lot of people are pushing to remove the word concussion from the healthcare vernacular because a concussion being different than a mild traumatic brain injury almost suggests that it's not as serious, that it's different, that it's maybe not even a traumatic brain injury because the word brain injury is not in it, when that's far from the truth. A concussion is a mild traumatic brain injury, and in some situations can lead to just as much quality of life issues as somebody who has a moderate or severe traumatic brain injury. So what exactly is a mild traumatic brain injury? Well, we already talked about this. There is no singular unified definition. However, the American Congress of Rehabilitation Medicine has a really good fitting definition of mild traumatic brain injury. And what they say is an MTBI is any traumatically induced physiological disruption of brain function with at least one of the following: a loss of consciousness not greater than 30 minutes, a loss of memory directly before or after, but less than 24 hours, an alteration of mental state at the time of insult, focal neurological deficits, transient or not, and a Glasgow Coma Scale not less than 13. Okay, so those are the criteria that you need to meet in order to have a mild traumatic brain injury. And you might be thinking, wow, if I lost consciousness for 29 minutes, it's still considered mild in the traumatic brain injury spectrum? And the answer is yes. So this is the best definition that I can find of concussion. This is done by the American Congress of Rehabilitation Medicine. What's the definition of a concussion? Well, to find that, we're looking at the most unified definition that's out there, the most well-accepted definition, and how we determine that is by the number of citations in the literature. And this is from the Concussion in Sport group. And they say that concussions are complex pathophysiological processes affecting the brain induced by traumatic biomechanical forces that may be caused by direct blow to the head, face, neck, or anywhere on the body with an impulsive force transmitted to the head. So that definition means that you don't have to have your head hit in order to sustain a concussion, which I think is very important to understand. And they also just added on in the last consensus that symptoms cannot be described or explained by drug, alcohol, or medication use, or other injuries such as cervical injury, peripheral vestibular dysfunction, etc., or other comorbidities such as psychological or coexisting medical conditions such as anxiety, schizophrenia, bipolar disorder, so on and so forth. Now, there are a couple different types of traumatic brain injury mechanisms, two to be exact. There's the focal mechanism and the diffuse mechanism. A focal mechanism is exactly what it says. There's a focus of energy that's transmitted to the head, which usually fractures the skull or can cause some sort of a bleeding in the skull where the injury occurred. So that would be called a subdural hematoma or an epidural hematoma. And that's typically meaning that the injury is at the site of the impact. These diffuse traumatic brain injuries are a little bit different. So this is a person's head. This is actually a cadaveric brain that I was able to prosect and to look at and examine. And this was an unfixed cadaver, meaning it didn't have any formalin or formaldehyde to keep it fixed. So this is what we would call, quote unquote, a fresh brain. And what I'm going to do in a second is just move that head ever so gently, and you're going to see how much energy and how much basically destruction can occur when somebody's head is shaken. You may have heard that the brain is the consistency of gelatin or pudding, and you'll be able to see it here. So this is me just slightly shaking this person's head, and you can see how that force is just transmitted through the brain. And in a diffuse traumatic brain injury, all of the injuries happen all throughout the brain, wherever there are types of tissues that aren't congruous. These are tissues that are not the same. So for example, the intersection between white and gray matter, the intersection between brain tissue and blood vessels, or where sulci and gyri are. This is where all of the injury happens, and it's all throughout the brain. In the fifth concussion consensus, the one that we call the Berlin consensus, they identified the 11 R's of concussion management. I'm not going to go through each one of them, but here they are, and we'll talk more about them in the functional neurology management of concussion. The first level, in chapter 1 particularly, we go through these 11 different R's of concussion management. Now, this patient that we're going to examine, she's 3 days out from her concussion, so we're not really looking to recognize if she had a concussion. We're not looking to remove her from any activities or play. We're not looking to confirm her diagnosis and reestablish her status. We're not even going to ask her to rest for 2 days. We're going to begin right at the process of looking at rehabilitating. But in order to rehabilitate someone, we need to know where we're starting from. So an evaluation at this point in time is very important for the acute management of concussion. Now, the big question, does diagnosis equal treatment? And the answer is no. Just because you're able to diagnose somebody with a concussion doesn't mean that there's a standardized protocol to treat them. As a matter of fact, when we start looking at the number one most utilized diagnostic tool, which is the SCAT-5, the Sports Concussion Assessment Tool, version number 5, created by the Concussion and Sports Group, what we actually find is that they say that you should not use this tool as a standalone method to diagnose somebody or measure the recovery or make decisions about their treatment and return to play. And then there is literature that says when you take this and combine it with multiple tests, you have a greater sensitivity and specificity. So the SCAT-5 itself has moderate to high reliability at about 2 weeks after the injury. It persists on a little bit farther to about 4 weeks, but after that, it really starts losing its reliability. However, the cognitive portion of it is only really reliable for about 6 hours after the injury. And then when we start looking at false negatives, meaning that somebody had a concussion and it says that they don't, they are as high as 32%, or 1 out of every 3. So we know that there has to be more done to identify how to help and how to diagnose individuals that have sustained a mild traumatic brain injury. And most importantly, the SCAT-5 doesn't tell you what to do for the patient. So when we start looking at individuals who've had a mild traumatic brain injury, there's this timeline here that we have established and that we typically follow. And it's broken down into 3 different groups: acute, subacute, and chronic persisting. And the time durations here are acute phases, usually 0 to 30 days, subacute is 31 to 3 months, and chronic persisting concussion symptoms or mild traumatic brain injury is 3 months and more. So here's the patient presentation. We have an individual who's a 69-year-old white female, and she's a pretty typical lady. Her body mass index is an 18 when she's pretty petite, she's pretty thin, right-handed, left-footed, so she's got some cross dominance there, left eye dominant. She's a non-smoker, non-recreational drug user. She drinks 2 glasses of wine per day, which if you look at that, that's 14 glasses a week, which is over the number of recommended glasses of alcohol or alcohol consumption for a woman. And that puts her into the category of a heavy drinker, not an alcoholic, but a heavy drinker, which may or may not play into her concussion. And we'll talk about this a little bit later. To ruin the surprise, it really doesn't cause a change in your prognosis, but it predisposes you to being more easily concussed because you're more likely to fall and make bad decisions when you're intoxicated. So here's the history of her present illness. So she was over at a friend's house. She was playing some card games. She had a little too much to drink. She stumbled and made head-to-head contact with another person. Never fell to the ground. She had no loss of consciousness, no amnesia, no nausea, no vomiting, no involuntary muscle contractions. And this was all corroborated by her friend who had driven her to the appointment and was there with her because she couldn't drive. Her symptoms were not present at that time. However, she just developed those symptoms the next day and included all sorts of things like headache, dizziness, confusion. She was hyper emotional, including anxiety, depression. She had some fatigue, and she also had intermittent blurred vision. And since then, the symptoms have actually worsened. Her presentation to me, she was alert, she was oriented, she was visibly uncomfortable. She was kind of squinting her eyes. Had some spontaneous crying and tearing. And she had a host of symptoms. She had 9 different symptoms with an average symptom severity of 3.44 out of 6. So this puts her in the moderate category of symptom severity. She stated that everything makes her symptoms worse, but only sleep makes them better. And she felt about 50% of her normal self. Now, when you see those things on the slide there, you see a little asterisk next to them. What I try to do in this case presentation is to discriminate what is included in the SCAT-5, what basically the SCAT-5 asks you to do, and what was above and beyond in what I did. So when you see a little asterisk, you're going to say, oh, okay, that's required by the SCAT-5. If you don't see the asterisk, it's something that I was doing to see if I can better manage that patient. She had one goal, and I only give people one goal. I say, if there's one thing that I can help you with, only one, you only get one wish, what would that one thing be? And that's often a hard question for people. And the reason why I ask it is because whatever the answer is to that question is what matters most to that individual. And she came out pretty quickly and said, just reduce my headaches, please, because I feel that everything is connected to them. Her review of systems, pretty unremarkable across the board. She suffered from migraines. She had a hysterectomy at age 51, and the reason why she had the hysterectomy is that she had an abnormal pap smear, and she had all sorts of reproductive problems her entire life with terrible migraines during after menarche and when she had her period. So essentially, she and her gynecologist agreed that it's probably best to just stop her periods altogether and I'll be on the safe side with a pap smear. From that, she had some mild incontinence, she gets frequent UTIs, and she has a history of genital herpes with no flares in 30 plus years. No real neuro background besides the migraines. She did have COVID twice, and she had an abnormal pap smear at one point in time, Epstein-Barr positive, and she believes that she has gluten sensitivity. So once again, not a very remarkable history. So one of the things that we want to start thinking about is the history of present illness and what it makes us think about. So the history of present illness itself should lead you to kind of understand and almost predict the future. So do certain people fare better or worse based upon their history and their history of present illness? And the answer is yes. Individuals who are less than 18 years old tend to have longer duration of symptoms. So that means that individuals who are a little bit older seem to get better quicker. And those with a history of prior concussions have longer syndromes, particularly if they've had their concussion in the previous year. And it's a kind of ironic or maybe even paradoxical to think about that those without the loss of consciousness actually take longer to recover. So say that differently, if you've lost consciousness from your concussion, research shows that for some reason you get better quicker. And most of all, the highest and the greatest predictor of symptoms, severity, and duration of recovery is the number and severity of symptoms at the time of injury. So our patient has, I think it was 13 symptoms with an average symptom intensity of 3.4. So she's on the moderate side. So we would expect her to take a little longer to recover. And the chances are she's probably going to come out of the acute phase with some lasting sequela. Oops, sorry. And the question is also, do certain phenotypes fare better or worse? We'll talk about phenotypes in just a second, but what I'll tell you is the cognitive phenotypes seem to recover faster. The people that have affect and vestibular phenotypes seem to recover slower. A history of migraine increases the probability of persistence. And also, this was kind of interesting, individuals who drink alcohol before, during, and after their injury of concussion don't really have any long-term outcomes that are any different from anybody else in mild and moderate traumatic brain injury. So that's a good thing for this lady, because we wanted to see if the predisposition was there from drinking before her injury. And typically somebody who's drinking 2 drinks a day every single day is not going to stop drinking. She may not drink while she has her symptoms, but she's probably going to start drinking pretty soon. So here are the different phenotypes. This was a great diagram that was actually published by the Concussion and Sport group to kind of discuss the symptoms, doing a factor analysis and figuring out how the symptoms kind of fit into different containers, and those containers are now labeled as phenotypes. And then it also talks about what you might find in the physical exam and how you might treat them. And the thing to understand most is that as far as symptoms, which are on the inner circle, symptoms overlap. You have overlapping symptoms between the different phenotypes. So it's so hard to say, because you feel like this, you are in this box. And the reality is that based upon symptoms, people are in multiple boxes at one time. And realistically, our examination really helps us figure out which of those boxes we need to work on the most. I would say in my experience, I don't think I've ever seen a patient that was in one single one of these phenotypes. No patients have ever had that after concussion that were just cognitive or just vestibular. They're always a mix of all of them. And that speaks to how the brain is kind of assembled. We kind of assemble all of our systems together to create the reality that we experience. Now there's 6 phenotypes here. Cranton discusses 7 phenotypes, and we'll talk a little bit about Cranton's analysis in just a minute. But they're both good, and they both pretty much overlap. Cranton just added in a cervical phenotype. So we'll talk about that in a minute. As far as the physical examination goes, here's what we did. We did the SCAT-5 because this is the bare minimum you should do when somebody has an acute concussion. You should do this on the sideline if it's a sporting event, at the scene of the injury if they're injured outside of a sporting event. And then also you want to do it on their reevaluation, 2 or 3 days after they've rested, just to kind of see what you're working with. So the way I've broken this down is the things that are done in the SCAT-5, once again, are asterisked, and the things that are not are not. So pain with passive and active cervical range of motion only at end range. So when we turned her head passively and when she did it actively, she had pain at all end range of motion. And her cervical range of motion was diminished in rotation, flexion, extension, and lateral flexion. Can we say that this is from her concussion without a baseline? No, of course not. She may have this from her arthritis. So we'll see how this all plays out. Nose finger was grossly normal and metric, meaning she was able to touch her nose and touch a target, but she had some terminal tremor on her right hand and right arm. Is this from her concussion? We don't know. Probably not, because concussions are not associated with cerebellar findings in the short term. Now, when we get some remodeling of the bigger networks, we may see some decreased cerebellar integrity, which then may result in it. But this may be something that was either pre-established before her concussion, or it very well could have been from her concussion. We have no way of telling that without a baseline evaluation. SAC, the Standardized Assessment of Concussion. We did the 5-word recall here. So this was before we started doing the 10-word recall. She scored a 27 out of 30. Her orientation was perfect. Her immediate memory was perfect. She had some decreases in concentration, meaning that she had a hard time doing the numbers in reverse order, and she missed 1 on the delayed memory. All in all, that's not a bad score. It's pretty much normal for someone her age. Balance testing. Once again, balance testing is part of the SCAT-5. She did really poorly on this. 43 errors. For her age, she's 69 years old. 39 is the max you want to see. So this puts her into a poor category. This is essentially 3 standard deviations or greater outside of the norm. So her balance was definitely affected, or definitely, we can't say it was affected. Her balance was definitely poor. We don't know if it was pre-concussion or from the concussion. Some other testing, looking at all the different phenotypes. I guess we'll pause here for a quick second. Everything that you saw up to this point that was asterisked in the last couple of tests are all that's included in the SCAT-5. So let me take a couple slides back. So if we go back here and we start looking at the SCAT-5, we would say, oh, she has no cognitive issues. She might have some cervical problems, and she might have some balance problems. And balance could be cervical, it could be visual, or it could be vestibular. So this really doesn't tell us anything about what's going on other than the fact that it looks like she may have had a concussion because the history suggests that she did. She bumped her head. She had some delayed onset of symptoms, and she has more than one neurological finding. Remember, from the definition that we gave you was an injury, and then with things like a transient neurological finding, loss of consciousness less than 30 minutes, amnesia less than 24 hours. So she does have neurological findings, and we just don't know whether they're transient or not just yet. So Coach CV, we'll talk about that in one slide from now. Coach CV is a mnemonic for you to remember the different phenotypes by Cranton and al. So Cranton et al. Said that this Coach CV stands for cardiovascular, oculomotor, affect, cognitive, headache, vestibular, and cervical. So one of the things that I've kind of looked at is trying to change things a little bit. Instead of calling things cardiovascular, because that's not really brain related, you typically don't injure your heart or your blood vessels with a concussion. You might injure oculomotor function, vision, affect, cognition, vestibular function, but you don't typically injure your heart and blood vessels. So I propose changing that to autonomic. And then the cervical portion of it, where people can have cervical injury, they can also have other body parts that are affected because of that. So I like to call cervical more somatic. But anyways, these are the 7 different categories that Cranton put together to help you remember how to kind of cluster in your examination and your symptoms. Here's how I would modify them: having an autonomic, an affective, a cognitive, oculomotor, visual, sleep, somatic, and vestibular. These are the categories that make sense to me. These are the categories where I can cluster some symptoms and I can actually build an examination off of. And this is what I'm going to do for you in chapter 1 of the functional neurology management of concussion. We're going to go through all of the different testing that you can do in each one of these categories and teach you how to correlate them with each other and devise treatment strategies for one or more of them. So here's the autonomic category. We looked at the Compass 31 score. She scored a 10, should be less than 12, so she's okay as far as autonomic symptoms. Body temperature is a little low, but hey, you know what? Older people's body temperature, their metabolism slows down a little bit, so it lowers a little bit. Oxygen saturation, decent. Blood pressure, a little bit low. We've got some concerns about perfusion at that blood pressure. Might cause some dizziness, so that may be associated with her dizziness. Heart rate 87, not abnormal for someone her age. Supine 71. Her heart rate variability 22, that's pretty low. What that would typically suggest to us is that she is probably a little bit more sympathetically dominant versus parasympathetically dominant. We want to see that above 40, between 40 and 100. So she's at 22, which is a little low. And then her heart rate upon standing is 92 beats per minute after 30 seconds of standing, which is only a 5 beat per minute change from seated and only a 21 point difference from laying down to standing. So we'd have to do some calculations on that to see if she has what might be defined as postural orthostatic tachycardia syndrome. It is 21 beats per minute, but we really want to look at 20 to 30% of her resting heart rate, and I think we're actually there. So she may have some of that postural orthostatic tachycardia syndrome, or one of the things you have to take into consideration, she might stand up real quickly and be in pain, and pain will raise your heart rate. So we have to look at the gestalt. It doesn't seem like she has a whole lot of autonomic signs here, so I would lean towards the side of saying, let's see if this pans out a little later and before we start doing things to help her in this situation. Cardiovascular, everything was pretty well normal. She did have an aortic and a mitral murmur. Aortic, typical with calcification. Mitral, typical with calcification and with age as well too. Valsalva was normal, and she did have a little bit of a carotid bruit on the left side, which may be very well from the aortic murmur just continuing into the carotid vessels. Looking at affect and health-related quality of life, her quality of life was low. She wasn't feeling very good. That's why the QOLS, the quality of life scale, she scored 69. Her PANAS, or her positive affect, negative affect score, She scored a 19 on the positive affect, which is more than 2 standard deviations low. And her negative was fine. So she's not negative at this point. She's just not happy. And her Euroquell visual analog scale was a 52 out of 100. So this is her quality of life assessment using a visual analog scale. So she put it smack in the middle. She doesn't wish she wasn't here, but she's definitely not living her best life. We didn't do the Qualibri on her. Cervical repositioning test, we'll talk more about what that is at another time, but she scored poorly, more than 2 standard deviations in right rotation, left rotation, looking down. Her thumb localization test was normal, so she doesn't have a proprioceptive issue. She probably has a cervical injury in this situation. Cognitive testing, she actually did okay for what we have. She's mildly impaired for digit symbol masking, substitution test, trail making test, and her reaction time, specifically her choice reaction time, was actually a little bit compromised. So we see that as far as cognitive testing goes, from a general scanning, not so bad. Part 2, we did Cambridge Brain Science, and what we found out is that she was in the middle of the road in a couple areas, but she was also not scoring so great in the spatial short-term memory, visual spatial processing, and response inhibition. As a matter of fact, out of those 3, I would say only visual spatial processing and response inhibition are considered poor. Spatial short-term memory would be on the low side of the average. So these are a couple things we want to look at. Now, why might somebody have visual spatial processing issues and response inhibition? Well, pain, the experience of pain has been known to decrease response inhibition. It decreases attention. So if you don't have attention, you're not going to be able to inhibit a stimulus. Now, why visual spatial processing? Well, if she doesn't know where she is in space, maybe because of a vestibular problem, which she did have poor balance, but we haven't done anything to assess her vestibular status yet. That can also explain visual spatial processing and spatial short-term memory. So let's see what else we have. Ocular motor assessment. We did a standard generic VOMS, a visual ocular motor screening. This was kind of put together by Mickey Collins over at UPMC, and it's a very good screening, and I use it to figure out if we need to do more in-depth evaluation, maybe some video oculography or things like that, saccadimetry. And her pursuits in the horizontal and vertical plane were decreased in their gain with catch-up saccades. They had increased headache and dizziness associated with them. And also we had saccades that were dysmetric to the right and upwards. And what she also did is every time she moved her eyes, she moved her head with the saccades. So typically suggesting that she's hypometric in all directions, but she was grossly dysmetric rightwards and upwards. And her convergence was severely impaired with a diplopia at 38 centimeters. Typically for someone her age, they're not going to get diplopia until about 11 centimeters from the tip of her nose. So you can see that this is pretty severe, especially with the one standard deviation being 3 centimeters. So she's, let's see, let's do some quick math on that. 28, 3 divided by 28. So she's 9 standard deviations off normal. So that's pretty bad. So it puts her in like the first percentile, like super, super low. Maddox rod, she had a right hyperphoria and a exophoria present. Now remember, with Maddox rods, you can't tell if somebody has a right exophoria or a left exophoria because when you're covering one eye, they're looking at the light. When you cover the other eye, they're looking at the light. So both eyes are just going to go out and alternate. But her exophoria at near was 11 diopters, at far was 3 diopters. Anything less than 10 diopters is definitely considered to be significant at near. So, and that would suggest that she has some convergence insufficiency, which we'll talk a lot more about another time. King-Devick test, 91.11 seconds with 2 errors. For her age, the normative value says she should be at 60 seconds plus or minus 15 seconds. So she's over 2 standard deviation units off from that. So you can see she's not doing so great in a lot of different areas. And had we not looked at any of these things, we wouldn't even know that she has all of this. From a visual component, her dominant eye was her left eye. She was suppressing her right eye at distance, but her left eye at near, which is kind of interesting. She alternates suppression. That tells you that it's probably a neurological mechanisms involved there. And most likely that's from her concussion. She may have always had left eye dominance, which means she would probably suppress her right, but the fact that she's suppressing her left at near point probably tells us that there's something that's more acute that's in progress here. Her static visual acuity with a Snellen and eye chart corrected with the glasses was 20/30 vision. Pretty good vision for a 70-year-old. But however, her dynamic visual acuity using a Snellen and eye chart was 20/70, meaning she lost 3 lines of visual acuity as she shook her head back and forth with that. So that's suggesting that she has a VOR impairment, a vestibular ocular response impairment. We did some peripheral field testing, looking at how well she can see things from her periphery. And she had the decreased ability to recognize only green and only in her right peripheral field compared to all colors in all the other fields. So that's something that kind of stands out to us and something that needs to be probably addressed if it doesn't resolve on its own. On the vestibular side of things, we already talked about her 3 lines of loss. Romberg's test was negative, which we probably would have known because of her balance error scoring system being pretty, not normal, but being impaired, but she didn't fall over on the first test. Fukuda's test, she had an 80-degree right rotation, head thrust. She had a grossly decreased VOR green bilaterally, meaning like I could see it when I moved her head back and forth, but there was a greater deficit with right rotation than left rotation. Looking at her ocular tilt response, she had decreased gain in right lateral flexion, and she had a negative Dix-Hallpike. So she didn't have any peripheral vestibular canalithiasis or anything like that causing her dizziness. We're digging a little deeper. Okay, her PSQI, her Pittsburgh Sleep Quality Inventory Scale, she scored a 7, less than 5 is normal. So as you see there, scoring greater than 5 yields a sensitivity and specificity of almost 90% in distinguishing poor and good sleepers in a sleep study. So we can almost predict the outcome of a sleep study with this. So in this situation, I'm thinking to myself that she may need a sleep study if this score doesn't get better. As far as treatment goes, here's what we're going to do. And I don't want to be anticlimactic here, but the reality is time and education are the 2 things that you do in this situation. That's exactly what we did. We did combine a couple other different things we'll talk about in a minute, but realistically, when you're at 3 days out from a concussion, the research is pretty conclusive that you're going to do time, education, and a graded cardiovascular protocol. Why did I not do graded cardiovascular protocol? Well, I just didn't feel comfortable with her age, with her balance, with her murmurs, and the bruit that I heard in her carotid. So I made a clinical decision not to incorporate graded cardiovascular training into her program. And my approach is you can always add it in. You cannot take it out after you've done it. So time and education was my prescription for her. What did I educate her on? Well, here's what the literature suggests that you should educate people on. And actually, they've shown that this type of education reduces people's symptoms and also expedites their healing in a randomized controlled trial. So we'll talk about this a little bit more in just a moment, but common symptoms associated with MTBI. So you want to tell her that, hey, it's normal to have dizziness. It's normal to have headaches. This is what people experience when they have concussion. Reassure them that you're confident in your diagnosis. Based upon what I've seen here, you've had the history of a head injury. You have the symptoms associated with it. So it sounds like we're pretty confident that you've had a concussion and you should follow the normal course of a concussion sequela. Give them symptom durations, and this is from the literature. Most people, 50% or more, will recover in 7 to 14 days. Those that don't usually recover in 7 to 14 days do so around the 21 to 30 day mark. So, and there's a small group of people that don't recover after 30 days and become more chronic, and we'll talk about those people at another time. But also good to mention to them that the symptoms that you can expect to go away first are nausea, depression, anxiety, dizziness, double vision. The symptoms that are the longest duration, usually 14 to 16 days, are headache, irritability, sleep disturbance, frustration, and poor concentration. And by and large, most people's symptoms are self-resolving. And then give them some coping strategies. If you feel like your headache's getting really bad, first try and lay down, close your eyes, get in a quiet space and just relax. If that doesn't work for you, try hydration, try drinking a bunch of water, see if that helps. If that doesn't work, go to some over-the-counter medications to make that headache go away. We don't want you to be in pain. We just want to give your body a chance to heal on its own. So different type of coping strategies based upon that individual. Some experimental physiology-related treatments, these are some of the things that we did do with them. But before you do any of these, make sure that you follow the number one rule. Do no harm. Make sure you understand the concussion pathomechanics, the pathophysiology, know what you're doing and how it's going to affect those things, because in some instances you don't want to do some of these different treatments. In other instances you do. Dr. Clark is of the opinion that you should not do any nutraceutical or supplementation during the acute phase. Some literature says it's experimental and they think that it may help a little bit. You kind of have to really just understand the mechanisms here and kind of figure out what you want to do. So what we did with this one individual is we had her buy a at-home transcranial photobiomodulation device in which she wore it on her head 20 minutes twice a day. And we actually had her come into the clinic and do some hyperbaric therapies. We had her come in daily for 5 days a week. And we did that for 3 weeks. So she had about 15 sessions in just to see if we can kind of promote some energy production, ATP production, and also both of those things increase blood flow to create the parity between energy demand and blood flow, because that's a typical thing that's mismatched in concussion. Some of the things that we did not do, but some people do, is manage the oxidative stress and apoptosis with nutraceuticals such as DHA, omega-3s, vitamin D, vitamin E, B3, zinc, magnesium, curcumin, some anti-inflammatories. Now, here's where we caution you on this. The inflammatory process is actually a good thing. Inflammation gets such a bad name, a bad rep, but realistically, imagine what would happen if you got a cut on your arm and you had no inflammation. It would never heal. So we want to be very judicious about when we try to decrease inflammation. The other thing that's really important to realize is that things like vitamin E, vitamin C, zinc, a lot of these are antioxidants, which cause oxidative stress. In some situations, they produce free radicals. Even though they're antioxidants, there's research that shows that it actually could increase oxidative stress. So we just have to be very careful with that. Specifically, vitamin C administration. The research is getting more conclusive that we should not give people with concussions vitamin C. At our 3-week follow-up, here's what we're looking at. Where you see something in highlighted and bolded in blue, that's something that improved. If you see something bolded in black, that's something that improved, but not substantially so. So she only had minimal pain with passive and active range of motion at the end range, where before she had pretty significant pain. Her standardized assessment of concussion went up 1 point, so she had delayed memory of 4, now at 5. So not really a significant change there. She was normal to begin with, and she's normal now. Her balance testing, she went from that high poor score down to 32, so now she's in the normal range on her balance testing for her age. Her oxygen saturation up at 99%. Her compass score is down at 5. Her blood pressure is now 118/77. Her heart rate variability is now up to 48. So we're feeling pretty good that she's autonomically more intact at this point. Same exact cardiovascular findings, meaning that these are probably not something that's resolving as a consequence of her concussion. Her affect and her health-related quality of life, she's definitely higher in her quality of life scale at 69, but that's still below average for her age. But her positive affect is definitely better. She's only 1 standard deviation low at this point, and she's definitely rating her quality of life better at 72 out of 100 versus being around 50 out of 100 before. No change realistically in the cervical repositioning test. She's still very poor on that. So it's kind of suggesting us that we definitely have some underlying cervical issues to fix. She's still 2 standard deviation or greater, no change at all in those. Cognitive testing, look at this. All blue, meaning that she all has substantial improvements in all of her cognitive testing. As a matter of fact, she's normal or fast as far as her cognitive processing abilities for her age in the digit symbol substitution test, trail making test, and reaction time. As far as Cambridge Brain Science goes, we still have some deficiencies here. They came up a little bit, but they're still not where we want them to be. The visual spatial processing is almost at the cusp of being on the low side of average, but the response inhibition is still and too low of a percentile for us to be happy with. Oculomotor assessment, basically nothing changed. We did have a little bit better with diplopia at 35 centimeters versus before she was kind of way out there. I think, if I remember correctly, going from my memory here, I don't have them comparison side by side. But we did see a nice improvement in her King-Devick time. She had 0 errors and only 1.6 standard deviations away from normal. So that did improve just by rest and education. Her vision, no big changes here. She still has the dynamic visual acuity loss. She's still suppressing abnormally, paradoxically, and she still has that difficulty recognizing that color green. Same thing with vestibular. We have a 5-degree improvement in Fukuda's from 80 to 75. But other than that, everything else is still the same. Her sleep, thank goodness it's getting better. She's scoring a 4 in the PSQI, which is less than 5, which means that we don't necessarily have to send her for a sleep study, which makes me feel better about her recovery, because the majority of your recovery, at least even after rehabilitation or even with rehabilitation or without rehabilitation, happens during sleep. So the fact that she's sleeping well is definitely working to our advantage. So as we move on to subacute management, here's what we have to consider. We only have 3 real remaining phenotypes: somatic, vestibular, and oculomotor. So these are the things that we want to focus on. And had we not done all of that testing 3 weeks prior, we wouldn't know what was there to begin with and what is improving and what is not improving. So what we're seeing is in Beth that her somatic, mostly her cervical dysfunction, her vestibular dysfunction, and her oculomotor systems are not improving. So we're going to want to create a rehabilitation plan moving into the subacute management to address those 3 phenotypes. How are we going to do that? Well, you'll just have to stay tuned until next time. So I hope you guys will join us for the functional neurology management of concussion. This is all from level 1, the acute management of concussion. And we'll be talking about some subacute management as well in the program. But more importantly, we're going to be going through all of these assessments in depth, explaining the neurology behind them, how to do them, how to grade them, understanding the scales associated with it, understanding the research to support it, getting those reference values, the standard deviation, so you know if somebody's far off from normal or not. Those are all of the things that are so important in level 1, because we're going to use all of those things to help build a foundation for level 2. So I hope you will join me on the journey through the functional neurology management of concussion, and we'll see everybody for the continuation of Beth's case next time when we start talking about her subacute management and how she did from there on. Take care and see you next time.